Welcome to the Mississippi Department of Mental Health Technical Assistance course for the Programs of Assertive Community Treatment, known as PACT, as well as Intensive Community Outreach and Recovery Teams, also commonly referred to as ICORT. This presentation is going to be a brief overview of both of these programs as they are incorporated into the Mississippi system of care. To get started, to better understand the purpose and mission of both of these intensive services, it's important to understand the populations to which are focused for both of these intensive service modalities. Mental illness is a brain disease that causes mild to severe disturbances in thinking, perception, and behavior, which can result in a significant inability or impairment to cope with daily life demands and routines, thus affecting ability to function occupationally or in educational environments or in personal family dynamics. Mental illnesses are common. More than 50% will be diagnosed with a mental illness or disorder at some point in their lifetime. 1 in 5 Americans will experience a mental illness in any given year. NAMI, the National Alliance on Mental Illness, provides some very compelling and important statistics to look at when trying to discern the impact and prevalence of mental illness in the United States. So what you can see here, as I noted just a moment ago, 1 in 5 U.S. adults experience mental illness. 1 in 20 U.S. adults experience serious mental illness. The differentiation between serious mental illness and mental illness is the level and significance of impairment in functioning. 17% of youth ages 6 to 17 years experience a mental health disorder. You can look at the 12-month prevalence of common mental illnesses across U.S. adults, as well as the 12-month prevalence of any mental illness among U.S. adults. You'll see from the infographics that the most common mental illness per most recent prevalence and epidemiological studies finds that anxiety disorders at 19% are the most prevalent, followed closely by depression at 8%, and then co-occurring substance use and mental illness at 8%. We cannot reiterate enough that mental health care matters. Mental health care, just as you would for physical or medical health care, is integral to quality of life and overall enjoyment and function within life. The average delay between symptom onset of a mental illness and treatment is 11 years. The majority of research that supports this noted statistic here in the infographic suggests that this delay between onset of symptoms and treatment is stigma. So breaking down stigma and focusing on the acceptance of mental health challenges and substance use challenges and disorders and diagnoses is integral to individuals being able to adequately engage themselves in treatment. People who get treatment in any given year, as you can see in this infographic, noted 47% of adults with mental illness, 65% of adults with serious mental illness, and then 51% of youth ages 6 to 17 with a mental health condition. As noted, I'll reiterate again, mental illnesses are very common. They can happen to anyone. No one is exempt, regardless of their age, race, income, or level of education. 1 in 5, or 19% of adults in the United States will experience a mental health condition in their lifetime. 1 in 24 adults in the U.S. experience a serious mental illness, or SMI. 50% begin by the age of 14 and 75% by the age of 24, highlighting the importance of early intervention. Mental illnesses are treatable with therapy, medications, or a combination of both. People who are diagnosed with mental illnesses can and do live happy, meaningful, and successful lives. Once again, we need to break down the stigma that those with mental illnesses are not able to enjoy or engage in life as their counterparts without a diagnosed mental health condition. Just like with any medical or other health condition, early identification and treatment plays a very important role in the success and prognosis of someone diagnosed with a mental illness. I wanted to highlight some risk factors that are commonly associated with mental illness. There are many risk factors that increase the probability that a person may develop a mental illness. This is just a short list and not an exhaustive list of risk factors that may impact the presentation or manifestation of a mental illness. These include traumatic events such as stress or abuse. For instance, the recent COVID-19 pandemic would be considered a traumatic event as it caused significant stress that impacted multiple domains of individuals' lives. Learned behavior, chemical imbalances. These are things that you might be familiar with in the research or media that look at serotonin or dopamine levels. Substance use, seasonal changes, such as seasonal affective disorder, where we see a significant increase in depressive and anxiety symptoms when we move from fall to winter. Previous episodes or experiences of mental health illnesses or the presence of another mental health illness can predispose you to manifesting additional mental health symptoms. For instance, it is not uncommon to have both major depressive disorder or significant depressive symptoms and an anxiety disorder or significant anxiety symptoms. Ongoing stress and anxiety builds and can continually provide additional risk. Medical conditions, especially chronic medical conditions, do play a role in development of mental illness. Hormonal changes, side effects of medications, or what sometimes are referred to as off-target effects. Illness that is life-threatening, chronic, or associated with significant pain, brain injury, and genetic predispositions. Here is a list, not an exhaustive list, of common traumatic events. These include assault, witnessing something terrible, mass traumatic events, military events, severe weather events, coping with the death of a loved one, painful medical procedures, and pandemics. Traumatic event isn't any incident experienced by a person that is perceived to be dangerous and threatens serious injury or death. A traumatic event may be a large-scale disaster, like Hurricane Katrina, September 11th, or COVID-19, or individual experiences. Common examples of traumas that affect individuals include accidents, assault, including physical or sexual assault, mugging, robbery, or family violence, witnessing something terrible, mass traumatic events include terrorist attacks, mass shootings, warfare, military activity, and severe weather events. These can also be precipitated and exacerbated by media exposure to mass traumatic events. Coping with the death of an important person in one's life is especially difficult, particularly for those who are young. So let's briefly review some common mental health diagnoses that might come up or occur for those that you will treat within PACT and ICORT service provision. Common mental health diagnoses include depression, anxiety disorders, schizophrenia, and bipolar disorder. All of these can also be considered a serious mental illness, especially if there is significant impairment to the level of functioning that severely impacts quality of life. We're about to address each of these in more detail, but it's important to understand that we're not teaching you to diagnose a person necessarily, because you may see them exhibiting some symptoms, but more to provide context on how to approach and understand the individual. Remember, every person that you treat in any treatment modality is unique. Their symptom presentation is unique to their life experiences and their current stressors and life circumstances. Schizophrenia. There is a large research base to suggest that schizophrenia has what's called a diathesis stress model, where there is not only a genetic predisposition, meaning it runs in families, but also that there's a significant life stressor that prompts the manifestation or presentation of symptoms of psychosis. So a person with schizophrenia tends to exhibit unusual behavior and strange feelings. They may suddenly start to have psychotic symptoms where they detach from reality or have depersonalization with the world around them. Psychosis or psychotic symptoms really refers to having strange or delusional ideology, thoughts, or feelings that are not based in reality. Schizophrenia and other disorders of psychosis are strongly encouraged to be treated with grounding strategies prior to any treatment modality. Bipolar disorder is a mental health disorder that results in extreme mood swings that include both emotional highs, which can be referred to as euphoria, mania, hypomania, and then extreme emotional lows, major depression. In popular media, it's inaccurately portrayed that individuals with bipolar disorder can swing mood-wise between a high and low within minutes or hours. That is not an accurate portrayal. But rather, bipolar disorder goes for days, several days, usually 4 to 5 days of an emotional high or manic episode or hypomanic episode, followed by a period of emotional low or significant depressive episode. When you become depressed, you might have loss of interest or pleasure in activities you once thoroughly enjoyed, feelings of extreme sadness or hopelessness, and difficulty with concentration. Mania or hypomania will present itself with increased energy, increased activities levels or goal-directed behavior, and a proclivity towards risk-taking behavior that might result in situations where an individual is in situations that may be risky or unsafe. Depression, as we touched on a moment ago, is a type of mood disorder. The main sign or symptom is when people are sad, discouraged, or irritable for weeks, months, or even longer. Another sign a person might have depression is negative thinking. So that self-critical negative thinking trap, or nothing will ever work, nothing is ever going to get better, there is no hope, is a significant sign of depression. There may be symptoms of concentration or attention difficulties, focus on problems and faults and blame rather than focus on solution, being extremely critical of not only themselves but others, and hypercritical and possibly open to complaining more often than not. As with all mental health illnesses that we've discussed so far, there is a significant impact on that person's ability to work and carry out their usual daily activities and to engage in quality, worthwhile, and meaningful personal relationships. Anxiety disorders focus on feelings of worry or feelings of an unease. It's an understandable reaction in day-to-day life. Individuals might feel symptoms of anxiety or might feel anxious because they have a presentation or because they're nervous about telling a loved one something that might be difficult to share. An anxiety disorder is when it meets diagnostic criteria where that worry or fear is above what would be expected or typical for the presenting concern. Anxiety affects their behaviors and thoughts on a daily basis and often interferes with school, home, and social life. Examples may include panic attacks, obsessive-compulsive traits or symptoms, but obsessive-compulsive disorder, let me point out, is a separate classification within the DSM-5 and is not considered an anxiety disorder, but you will often see them co-occurring. Anxiety disorders, as I touched on at the beginning of the presentation, are one of the most common mental illnesses in the United States, affecting roughly 4 million adults, 18 and older, which is about 18.1% of the population, and approximately 25.1% of children between 13 and 18 years old. So now that we've very briefly, that was not an exhaustive presentation of mental illnesses that you might come into contact with or might have experience with in your role within your PACT and ICORT teams, but just wanted to provide a brief overview. It's very important that you review and read literature and research and clinical treatment information specific to serious mental illness, since the majority of individuals that you will be treating within these modalities are going to have an SMI, which is the abbreviation for a serious mental illness. Knowledge is power, and knowledge is key when working with individuals and being of the greatest service to them. So let's briefly discuss assertive community engagement. Assertive community engagement is the context or modality for both PACT and ICORT. Assertive community treatment, based within PACT, which what we've referred to in Mississippi as programs of assertive community treatment, PACT for short, is an evidence-based practice. There are 4 components or parts of evidence-based practice. It's important to understand that the treatment modalities that you're engaging in with your clients is evidence-based, and to highlight that to both current and prospective clients. So one component or a part of evidence-based practice is that there is a specific intervention, and within that intervention there are standards or a model that should be followed, and that is based and housed within research. Another component is system outcomes or consumer outcomes. What is being done matters and has results. Those results, third component, should be predictable and reproducible. Just like with any research, being able to replicate is a very important and integral part of any research study to be able to test and retest the validity and reliability of a treatment modality. And then fourth and finally is the assessment tool for an evidence-based practice, which is the fidelity instrument. Both PACT and ICORT have fidelity tools and scales that are utilized by your fidelity reviewers when looking over and assessing and evaluating your team, your staff, and the clients to which you serve. The research on EBPs tells us that the combination of effective intervention practices such as assertive community engagement and effective implementation practices, putting it out there to the community, results in good outcomes for consumers. No other combination of factors reliably produces desired outcomes for your clientele. There is a very strong evidence base for assertive community treatment that is at the foundation of PACT and ICORT. Known outcomes for assertive community treatment have been shown to address the following. There is strong research, empirical evidence that it decreases the need for hospitalizations, increases treatment retention, increases overall satisfaction with services by the consumer, and improves housing stability. I would also like to add that there's a significant research to support that it improves employment as well as improves the quality and salience, meaning positive interpersonal relationships and connections with others. There's moderate research or empirical support for decreasing substance use and reducing criminal justice involvement within the system, and then overall improvement in the quality of life. So what does assertive community treatment solve or address from its evidence-based approach? What it looks to address is the fragmentation of services. That's why there's a strong treatment team component that reduces that fragmentation and creates a cohesive treatment unit. It addresses institutionalization. The goal of both of the treatment modalities and the technical assistant course is to address the reduction of unnecessary institutionalization by maintaining these individuals in a highly intensive wraparound service within their community, to maintain them in the community and help them manage and stay on the road of recovery. It addresses level of need that may not be addressed by traditional outpatient services. Many of the individuals that are appropriate for PACT and ICORT have not been successful and have not received the outcomes that they want or need from traditional outpatient care. It reduces overall system costs as well as overall resource utilization. Many individuals that utilize these services are high utilizers of these services. And so by focusing on an evidence-based approach from a treatment team modality, it should reduce this high utilization of other resource components within that community. It's very recovery focused and on maintaining and sustaining recovery. It also helps address staff burnout, so there's not a single staff person that is responsible for a given caseload, but rather it's a treatment team. It also addresses the need from a research and clinical standpoint that implementation of evidence-based practice is the best approach. Principles of assertive community treatment. So I want to stress here, PACT and ICORT are not case management programs. Neither of these service delivery models are meant to be a case management model. The primary goal is recovery-focused intervention through community treatment and habilitation. The principles of ACT continue to be highlighted through the characterization of critical ingredients that we'll touch on in just a moment. For consumers with the most challenging and persistent mental illness and co-occurring mental illness and substance use disorders, PACT has a strong research and evidence-based empirical model of support. Programs that adhere most closely to the PACT model are more likely to get the best outcomes. Here you see the critical components or critical ingredients of assertive community treatment. I've touched on many of these, but let me highlight. Multidisciplinary staffing, that's your treatment team model. The team approach to services. Low client to staff ratio. A holistic approach, meaning treating the individual as a whole and not a set of symptoms. The service provision being in the community. Medication management being integrated into this treatment modality. Focus on everyday problems in pursuit of recovery-focused solutions to maintain employment, maintain family engagement, and be maintained in the community. Continuous coverage and support. Assertive outreach. And long-term plans of care. Now that we've discussed assertive community treatment in a generalized manner, I'd like to jump into the Mississippi Department of Mental Health overview of PACT and ICORT that's currently offered throughout the state. So what does Mississippi's mental health service delivery system look like? We have three major components: state-operated programs and community service programs, regional community mental health centers, and other nonprofit service agencies and organizations. DMH strongly believes in community-based services and supports that meet that particular need of the individual, and that those should be available and accessible to them in their community. DMH-operated behavioral health programs. Those include Mississippi State Psychiatric Hospital and its satellite program, the Specialized Treatment Facility, or STF, East Mississippi State Hospital and its satellite programs, North Mississippi State Hospital, South Mississippi State Hospital, and Central Mississippi Residential Center. Programs of Assertive Community Treatment, or PACT. There are 10 PACT teams across the state of Mississippi. PACT teams, as we'll talk about in just a minute, are mobile and provide services in the homes and in the communities. You'll see the counties highlighted in the infographic on the slide are those that are directly served by the 10 active PACT teams. And in FY22, 760 individuals were served through PACT, and you'll see that as an increase from its inception at 384 individuals served. So what are programs of assertive community treatment? As we've discussed, assertive community treatment, such as PACT, focuses on individuals who have the most severe and persistent mental health problems, and those that have not benefited from traditional outpatient services. PACT services are mobile. They go where the client needs them. Those can be provided to the individual. Services can be provided to the individual in their home or anywhere within their community. I wanted to provide for easy reference the DMH operational standards. The DMH operational standards, most recently published in 2020, should be easily accessible on the Mississippi Department of Mental Health website, but for easy reference, I've included both the PACT and ICORT operational standards that are most relevant to the current presentation in the slides for your easy reference. Rule 11.6 refers to the qualifications for programs of assertive community treatment. There needs to be a team leader, and that team leader must have at least a master's degree in nursing, social work, psychiatric rehabilitation or psychology, or as a psychiatrist. The team leader must be professionally licensed or have a DMH credential as a certified mental health therapist. There must be a psychiatrist or psychiatric nurse practitioner who works on a full-time or part-time basis and must meet applicable licensure requirements or state boards. Registered nurse, and that registered nurse must be licensed and in good standing with their board. Master's level mental health professionals, and those professionals have professional degrees in one of the core mental health disciplines, clinical training including internships and other supervised practical experiences in a clinical or rehabilitation setting, and clinical work experience with people with severe and persistent mental illness. Substance use disorder specialist, a mental health professional with training and experience in substance use disorders assessment and treatment, because as we've noted, it is not uncommon to have co-occurring mental health and substance use disorders. An employment specialist, which is a mental health professional with training and experience in rehabilitation counseling. Peer support specialist professional, at least one full-time equivalent certified peer support specialist professional should be on the team. And then remaining clinical personnel, maybe bachelor's level and paraprofessional mental health workers. Rule 32.1, the service components of programs of assertive community treatment. So PACT is an individual-centered, recovery-oriented mental health service delivery model for facilitating community living, psychological rehabilitation, and recovery for people who have the most severe and persistent mental illness, have severe symptoms and impairments, and have not benefited from traditional outpatient services. The important characteristics of PACT are: PACT serves people who have gone without appropriate services. Consequently, the individual group is often overrepresented among the homeless and in jails and prisons, and has been unfairly thought to resist or avoid involvement in treatment. Programs of assertive community treatment services are delivered by a group of multidisciplinary mental health personnel who work as a team and provide the majority of the treatment, rehabilitation, and support services to people who need to achieve their goals. Many, if not all, employees share responsibility for addressing the needs of all people requiring frequent contact. PACT services are individually tailored to each person and address the preferences and identified goals of each. The approach with each person emphasizes relationship building and active involvement in assisting people with severe and persistent mental illness to make improvements in functioning, to manage their symptoms better, and to achieve their individual goals while maintaining optimism. PACT is mobile and delivers services in community locations to enable each person to find and live in their own residence and find and maintain work in community jobs rather than expecting the person to come in for a traditional service. PACT services are delivered in an ongoing rather than time-limited framework to aid the process of recovery and ensure continuity of care. Severe and persistent mental illnesses are episodic disorders. There will be periods of highs and lows, and many people benefit from the availability of a longer-term treatment approach and continuity of care. This allows people the opportunity to decompensate, consolidate gains, and then take steps forward until they achieve and maintain their recovery. Rule 32.2 looks at PACT staffing, which I've already briefly mentioned. But just to highlight, the treatment team must have the organizational capacity to provide a minimum employee-person ratio of at least one full-time equivalent employee for every 10 individuals served. Each program of assertive community treatment team must have sufficient numbers of employees to provide treatment, rehabilitation, and support services 24 hours a day, 7 days a week. In addition to meeting the qualifications outlined in Part 2, Chapter 11 of the Operational Standards, the following positions are required for PACT: the team leader, psychiatrist, psychiatric nurse practitioner, at least 2 full-time registered nurses, at least 1 master's level or above mental health professional, at least 1 substance use specialist, at least 1 employment specialist, at least 1 full-time equivalent certified peer support specialist professional, and then the remaining clinical personnel may be bachelor's level and paraprofessional mental health personnel. Rule 32.3, PACT admissions and discharges. I will not read this word for word as there's a lot of information, but wanted to highlight that admission into PACT is for those individuals with significant functional impairments that have been demonstrated by at least one of the following conditions: significant difficulty consistently performing the range of practical daily living tasks required for basic adult functioning in the community, or persistent or recurrent difficulty performing daily living tasks except with significant support or assistance from others, such as friends, family, or relatives. Significant difficulty maintaining consistent employment at a self-sustaining level, or significant difficulty consistently carrying out the homemaker or household roles. Significant difficulty maintaining a safe living situation, such as repeated evictions or loss of housing. People must have 1 or more of the following problems, which are indicators of continuous high service needs, typically greater than 8 hours per month. High use of acute psychiatric hospitals, typically 2 or more admissions per year, or psychiatric emergency services. Intractable, persistent, or very recurrent severe major symptoms, including affective, psychotic, and suicidal symptomatology. Coexisting substance use disorders of significant duration, typically greater than 6 months. High risk or recent history of criminal justice involvement, including arrest and incarceration. Significant difficulty meeting basic survival needs, residing in substandard housing, homelessness, or imminent risk of becoming homeless. Residing in an inpatient or supervised community residence, but clinically assessed to be able to live in a more independent living situation if intensive services are provided, or requiring a residential or institutional placement if more intensive services are not available. Difficulty effectively utilizing traditional office-based or outpatient services. Discharges from PACT occur when people and the agency provider employees mutually agree to the termination of services. Let me again highlight that this is a mutual decision. This must occur when people have successfully reached individually established goals for discharge and when the person and agency provider employees mutually agree to the termination of services. Have successfully demonstrated an ability to function in all major role areas without ongoing assistance from the agency provider, without significant relapse when services are withdrawn in a step-down fashion, and when the person requests discharge and the agency provider employees mutually agree to the termination of services. Move outside the geographic area of the PACT team's responsibility. In such cases, the PACT team must arrange for transfer of mental health service responsibility and coverage. The PACT team must maintain contact with the person until the service transfer is complete and implemented. Decline or refusal of services and requests for discharge despite the team's best efforts to develop an acceptable individual service plan with the individual. Rule 32.4 looks at the requirements for PACT contacts. You are welcome to read through this at your own speed, but I want to highlight that this is a high-frequency treatment care model. So this is a model that is looked at 7 days a week care, typically looking at 2 to 3 times per day at most to several times a week. But again, it's based on the individual needs of each client and what they need to function within their community and reduce unnecessary psychiatric hospitalizations. So I'll give you a moment to look. Feel free to pause. Rule 32.5 looks at PACT employee communication and planning and documentation associated with such. I would recommend pausing here to read at your own pace. Rule 32.6 looks at Program of Assertive Community Treatment employee supervision. It's extremely important for each agency to have a supervisory model that allows the staff within the treatment team to have a plan and support as individuals that engage as a treatment team member for PACT and ICORT experience high-level stress or CAN and vicarious trauma and engagement when working with individuals who are experiencing serious and persistent mental illness. It's important to highlight self-care of employees who are treatment team members in both of these treatment modalities. Rule 32.7 looks at PACT required services. You'll see that it is broken down to include service coordination, individual treatment team planning, crisis assessment and intervention, symptom assessment and management, medication prescription, administration, monitoring, and documentation. Again, I encourage you to pause and read through this at your leisure. It also includes activities of daily living, social interpersonal relationship and leisure time skill training, peer support services, and then finally education, support, and consultation to people's families and other major support systems. Again, I encourage you to pause and read through this at your own pace. Before jumping into ICORT, I want to again reiterate how important the work is of those in PACT and ICORT teams. You guys are doing significant and important work in helping individuals maintain recovery in their communities. ICORT is developed and based from the PACT model. So intensive community outreach and recovery teams, or ICORT, are designed to reach more rural areas where staffing might be difficult to maintain the fidelity of the PACT model. Currently, in Mississippi, there are 16 operational ICORT teams. These are included in Region 2, Region 6, Region 7, Region 8, 9, 10, 11, 12, and 14. In FY22, the 16 ICORT teams served 610 clients at their respective community mental health centers. 94% were maintained in their community without the need for greater inpatient services. So as noted, all of the criteria for admission and discharge to ICORT are the same as PACT. The main difference looks at staffing requirements that would allow for more appropriate coverage of rural areas. So ICORT teams are staffed with a registered nurse, master's level mental health therapist, certified peer support specialist, administrative assistant, as well as a medication provider. Here you will see a breakdown of the ICORT service within the respective counties covered within the catchment areas of the community mental health centers. The ICORT operational standards I'll briefly review, but I will leave out the redundant pieces that mirror the PACT operational standards that we just reviewed. Rule 11.7 looks at the qualifications for intensive community outreach and recovery teams, known as ICORT. These include a team leader who must have a master's degree in a mental health or related field and a professional license or DMH credential as a certified mental health therapist, a registered nurse that must be licensed and in good standing, a certified peer support specialist, part-time clerical employees, part-time community support specialists. You'll see that a substance use and employment specialist are not required for ICORT. Again, this is related to coverage of more rural areas where such staffing might be more difficult. Rule 32.9, the Intensive Community Outreach and Recovery Team is a recovery and resiliency-oriented, intensive, community-based rehabilitation and outreach service model for adults with a severe and persistent mental illness. It is a team-oriented approach to mental health rehabilitation intervention and supports necessary to assist people in achieving and maintaining rehabilitative, resiliency, and recovery goals. ICORT services are provided primarily in natural settings and delivered face-to-face with the person and their family as appropriate to the primary well-being and benefit of the consumer. ICORT assists, just as PACT, by maintaining the individual in their community in pursuit of recovery and resiliency goals. Rule 32.10 looks at the service components of intensive community outreach and recovery. So here, the agency providers of ICORT must also meet rules 32.5, 32.6, 32.7, and 32.8. So I encourage you to go review those in your operational standards. Rule 32.11 looks at ICORT staffing. So each ICORT team member, so there are 3, will serve a maximum of 45 people with a ratio of 1 to 15. So again, each intensive community outreach and recovery team of 3 staff will serve a maximum of 45 people with a ratio of 1 to 15, which is slightly higher than the 1 to 10 for PACT. Each ICORT team must have sufficient number of employees, at least 3, to provide the treatment, rehabilitation, and support services 24 hours per day, 7 days per week. Intensive community outreach and recovery can also utilize the Mobile Crisis Emergency Response Team, commonly referred to as MCERT, for assistance with on-call, but the response to a crisis by a person enrolled in ICORT must be a member from the ICORT team. The following positions are required for ICORT teams: team leader, full-time registered nurse, full-time equivalent certified peer support specialist professional, part-time clerical personnel, and part-time community support specialist. Rule 32.12, ICORT admissions and discharges. This reiterates the same that we have covered for PACT, but I'll give you a moment to read at your own pace. Here you see again the typical indicators of continuous high volume service needs or high utilization that are appropriate for individuals who would be eligible for PACT and ICORT services. Here I recommend pausing and again reviewing the standards. Rule 32.13, Intensive Community Outreach and Recovery Team Contacts. So ICORT team must have 75 to 85% of intensive community outreach and recovery work and supports and contact time in a community setting. You can read further down specific to the contact and frequency requirements. So I hope the review of PACT and ICORT has been helpful to provide a context for the importance of the services being rendered by these treatment teams. The operational standards mirror the fidelity mechanisms for the tools and assessment instruments that are used by fidelity reviewers when reviewing these very important services. If you have any programmatic questions at all, please feel free to direct these to the Division of Adult Community Mental Health Services within the Bureau of Behavioral Health Services. You're welcome to contact myself, Mallory Malkin, our Bureau Director, Mr. Brent Hurley, Division Director, Ms. Stephanie Berry, and Programmatic Specialist for PACT and ICORT, Ms. Willie Mayberry. Any technical assistance or course-related questions can be directed to the Office of Utilization Review, to Ms. Stephanie Foster. Thank you so much for participating in this technical assistance course.